I'm now going to demonstrate how to use a MPA. MPAs are used to maintain an airway in patients with a GCS less than 8 and where OPAs are not appropriate. Contraindication of the MPA is basal skull fractures or severe head injury like a TBI. To measure the MPA, you want to measure from the nose to the earlobe. You can do so like this, so that one's too short. And if you take this one, it's much better. And before you insert, first of all you would like to lubricate it so that it doesn't cause discomfort and slides in easily. Inserting it, you want to insert 90 degrees towards the face and twist slightly if you are encountering resistance. Insert it until the flange meets the nostril. Complications of an MPA include bleeding and resistance if the patient has nasal polyps. So now I'm going to show you how to administer oxygen. You can identify the bottle by the label here. For training purposes we are using compressed air, but in the real life scenario it would have a label with saying oxygen. It will also have some tags up here, and you can also identify a bottle without tags or a label by the 3 prongs that you have up here. It goes on top of the oxygen bottle here. Before we put it on, we want to check that the Botox seal is intact. If it's not intact, it can cause leakage. Line up the regulator with the 3 holes, and we slowly slip that one on, making sure to line it up and inserting the holes. We will turn the handle here until it's nice and tight, and then just release it a little bit so it's not too tight. We'll then open up the oxygen bottle and we'll see how much pressure is in there. So we've just got a little under 1000 psi pressure in our oxygen bottle. To let the oxygen run, we have this little knob here, and this will show you your flow rates in litres per minute. So right now it's sitting at 6 litres per minute. There are many types of oxygen masks. This is the nasal prongs, and they administer 20 to 40% oxygen at 2 to 4 litres. This is the acute mask. This one runs at 6 to 8 litres per minute, and it provides 60% oxygen. So this one's a nebulizer. This one is used to administer liquid drugs, and this one runs at 8 litres per minute. This one is a high concentration mask. This one runs at 10 litres per minute and provides 90% oxygen. And lastly, this is a bag valve mask. This runs at 10 to 15 litres per minute and provides 100% oxygen. So for the purpose of this demonstration, we're going to use a acute mask, and we're going to administer oxygen to this patient here. You want to attach the mask here. Make sure it's nice and tight, and before we put it on the patient, we want to unlock the top of the bottle and turn it on to its flow rate, which is 6 to 8 litres for this acute mask. We want to lay the bottle down, providing that it doesn't fall over, and we want to place on top of the patient, and we will pull the elastic until it fits nice and snug. You can tighten by pulling the elastic on the sides here, and also by using the metal cap for the nose. Indications for oxygen include shorter breath, respiratory disorders, oxygen saturations below 94%, traumatic brain injury, shock, altered GCS. We'll take this off. Just hang on a second. So we'll take this off, and we want to close the valve here and pull off our mask. We want to shut the bottle cap, and to bleed the oxygen out, you want to open the cap with the bottle shut, and that's bled the regulator there. How to insert an OPA. OPAs are used to gain an airway on a patient with a GCS less than 8. A couple of a contraindication of the OPA is a intact gag reflex. So first of all, you want to measure the OPA from the corner of the mouth to the mandible, like so. And then to insert, you want to first of all head tilt chin lift, get your OPA, insert to the roof of the mouth, and twist 180 degrees, ensuring not to catch the tongue, or move it posteriorly, and insert until the flange meets the lips. A couple of complications of the OPA include induced vomiting and damage to the oral pharynx. I'm now going to demonstrate how to use the suctioning unit. So first of all, you would like to test the unit. You can do so by turning it on full power and pressing test and holding the pipe in like so. This is going to test the max PSI of your suction unit, and as you can see by the dots there, it's ready to go. So just test it off, release that. Alright, now before we suction the patient, we want to place them in a lateral position. This helps to get any foreign fluids, liquids or objects from the mouth in a more natural way. So suctioning the patient, you want to turn it on and you want to place the catheter into the mouth only as far as you can see. You want to hold the hole there to produce suction, and suction in a circular motion on the way out only. You can only suction for 10 seconds. You should never use the rigid catheter in a moving vehicle, and there is a soft catheter for this purpose. Complications of the suction unit can be hypoxia, induced bradycardia, induced vomiting, aspirations, and damage to the roof of the mouth. Now I'm going to demonstrate how to use a bag valve mask. So first of all, when you test the bag valve mask, you want to test it by holding pressure on here and applying pressure there to see if there is any leaks. So there's no leaks in this one. Then you would like to inflate the reservoir, see if there's any leaks in there. And this one's pretty good. Alrighty. So we use a bag valve mask to assist ventilation of a unconscious patient. You want to insert an OPA, and you do so by measuring and getting the right size, pointing to the top, twisting 180 degrees, and inserting the OPA. Now, also with the bag valve mask, you want to be using oxygen with it, and we use 10 to 15 litres, and we make sure that the oxygen is running before we put it on the patient. Also, you want to put that on, and you want to check that the reservoir is inflating. Now, because I'm a single user, I'm going to be applying a CE grip like so, and with every ventilation we want to check for chest rise. So there's good chest rise there, and we want to ventilate only once every 5 to 8 seconds. Now, if we have any bystanders or another team member, we can apply cricoid pressure to close the esophagus and prevent gastric inflation. So the acronym MOANS is used to assess the bag valve mask for effectiveness in the patient. Now I'm going to demonstrate how to take the vital signs. So the first vital sign that we're going to take is the heart rate, and to do this we need to touch Martin's hand, so I'm going to ask for consent first. Is it okay if I touch your hand by taking the heart rate?
Yes, go ahead.
Okay, so I'm just going to rest your hand here. I will place my 2 fingers here, and we're going to be feeling for a pulse for 15 seconds. So Martin's pulse in that 15 seconds was 20 beats. So if we times that by 4, that brings us to 80, and that's within the normal range. Also, his pulse was strong and regular. Next vital sign I'm going to take is the blood pressure. As always, we have to ask for consent before we do this, as this can be uncomfortable. Martin, I'm just going to take your blood pressure. Is that alright? Yes. This might be a little bit uncomfortable. I'm just going to roll your sleeve up, just because we need the clothing out of the way. And we want to place like so firmly on the arm. Get our pressure reading, like so. We want to line the artery up with the artery on the arm. Take our stethoscope. Place it on the arm there. Now just get you to rest your arm there. And we're going to pump it up until we don't hear any more sound. As we release, the first sound that we're going to hear is going to be the systolic blood pressure, and the last sound that we hear will be the diastolic. So release the pressure slowly. Alright. Thank you, Martin. Thank you, Martin. So while listening to Martin's blood pressure, I heard that the systolic was 130 and the diastolic was 90. So the next vital sign I'm going to take is Martin's respiratory rate. To take the respiratory rate, you don't really want to tell your patient that you're going to take it. So a good way to take it is to distract them by asking to take the heart rate once again. So I'm just going to take the heart rate. If that's okay. We're going to take the respiratory rate for 15 seconds. So Martin breathed 3 times in that 15 seconds. If we times that by 4, that takes us up to 12, and that is within the normal range for a respiratory rate. We also want to check for the depth that he's breathing at and if he's using any accessory muscles to breathe. I'm now going to auscultate Martin's lungs. To do this we have to lift up his shirt, so we really do need consent for this. Martin, is it okay if I auscultate? It's going to require me to lift up your shirt. Yeah. Thank you. Now to auscultate, we're going to listen to each quadrant of the lungs, front and back, and we're listening for any crackles, wheezes, or dull sounds in the lungs. So I'm just going to go up here first. So Martin's lung sounds were free of wheezes, crackles or dull sounds, so that indicates that he is healthy. I'm now going to demonstrate how to bandage a wound. So first of all, you want to expose the wound. Just get you to take your hand off there. You also want to clean the wound with saline to get all the dust and foreign particles out of there. You want to get the smallest bandage that you can by folding. A bandage is a good way to get more pressure on the wound. Place the bandage on there, apply direct pressure. You can get your patient to do so like so. Get the bandage, and you can, I'll just get you to hold that there. Roll it up and lift your arm. And just you can tighten the bandage by twisting. After you've bandaged, you want to check for colour warmth sensation and a distal pulse, and also if the bleeding has stopped. Now, in the case of catastrophic hemorrhage where the blood does not want to stop, you want to apply a cap or a tourniquet. To apply the tourniquet, first of all you want to inform your patient that this is not going to be very comfortable. And then you want to apply 10 centimeters proximal to the wound. You apply the tourniquet by looping through the buckle. And pulling firmly down on the strap there. Tie down the tourniquet until the distal pulse or the bleeding stops. You can tie down the tourniquet by twisting this windlass here and then after that, document the time. This is very important. If the bleeding does not want to stop, you can apply another CAT proximal to the first one. When applying the cervical collar, you want to utilize the Nexus rule and the Canadian C-spine rule. So a couple of indications for using a cervical collar would be midline posterior C-spine tenderness, which you can feel, which you can identify by palpating the back of the neck just yet. If the patient is intoxicated, if they don't have an alert mental status or 5 out of 5 on the verbal scale, if they have any neurological deficit, so pins and needles or numbness in the extremities of the body, and no other painful or distracting injuries. The Canadian C-spine rule describes high-risk factors that can cause C-spine injuries, so it's like a fall from height or a high-speed impact. Now before you want to apply the cervical collar, you want to gain consent and explain the procedure to the patient, and then you'll get somebody, a bystander or a team member, to come and stabilise the head. Thank you. To measure the collar, you want to use your fingers from the top of the clavicle to the chin. Now as you can see, that's about 4 fingers. So you measure on here 4 fingers, and you use the locking device here to secure that in place. You just want to slide this under the back, give that a good squeeze to make it a bit more comfortable. Make sure the chin and the neck is immobilized. I'm now going to demonstrate fracture management. So when we approach the patient, we're going to ask him for a history, and we're going to use plastis to assess the suspected fracture. So can you tell me how you did this to your arm?
Oh, I just tripped and fell on it.
Just tripped and fell on it, okay. Can you tell me about your pain? Is on a scale of 1 to 10, 10 being the worst that you've had, where are you at?
Say it's a 7.
A 7. Alright, so now I'm also going to be looking for any unusual movements, swelling, deformities, irregularities, shortening, crepitus and shock. Once we've assessed it using the plus discs, I'm going to ask him once again what his pain is.
Oh, still a 7.
Still at a 7. And then we're going to administer some pain relief for him. So before we administer the pain relief, which I've chosen methoxyfluorine for, as it's got a rapid onset and the patient is able to obey commands, I'm going to ask for contraindications of the drug. So, excuse me sir, but have you any family history of malignant hypothermia?
No.
Have you any known allergies to methoxyfluorine?
No.
Have you any renal impairment?
No.
Have you had this in the last week?
No.
No. And you are able to obey commands. Before we administer the drug, we're going to do a drug check. Because my offside is not here, I'm going to use the patient. So we're going to be looking for the 5 R's. We're going to be looking for the right patient, the right drug, the right dose, the right time, and the right route. So this is methoxyfluorine, expires in 2018, and this is 3 mils. I'm going to be using 3 mils of methoxyfluorine. The maximum dose that you can give is 6 mils. Alright sir, I'm just going to get you to suck on this, and make sure you breathe in and out.
Okay.
Deep breaths please. Alright, before I start splinting, I'm going to assess neurological and cardiovascular integrity. We do this by taking a pulse. I can feel that quite strongly. Look for a cap refill too, and it's less than a second. Also, I'm going to ask him if he can feel my fingers on his fingertips. Can you feel them?
Yeah.
Good. Okay, so now we're going to be I'm going to ask him about his pain once again, see if the pain relief has kicked in.
Yeah, it's getting better.
We're now going to use a box splint with a towel to provide support for the patient's fracture. Right, are you able to lift your arm? Good lad. I'm just going to put that there. We're going to use bandage. How's your pain feeling now, sir?
Yeah, some still probably two.
That's good. Alright, so now that we've splintered it, we're going to once again assess the cardiovascular and neurological integrity. So once again I can feel a good distal pulse. I'm going to check for cap refill quite quickly, and I'm also going to be touching his fingertips once again to assess for neurological activity. Can you feel that?
Yeah.
Cool. Alright, that's good. We're now going to use a sling that I prepared earlier, and I'm just going to put this over your head, Martin. And if you'll be able to lift your arm up. Yeah. That's lovely. How are you feeling now?
Yes.
Still
Need my pain relief.
Alright, so this is my ECG monitor and defibrillator familiarization OSCE. On the right hand side here we have our pre-lead ECG, our ETCO2 and our SPO2 monitors. Martin's just got the ECG leads on there so you won't be able to see them. Up the top here we head on up to the blood pressure, non-invasive blood pressure cuff that we keep in the back here of the ECG. On the left side we have our defibrillator pads, our test load and our 12 lead ECG. We also keep aspirin, GTN and a razor in here. In the back we keep our spare ECG pads, ECG dots, and under here, and a spare roll of ECG paper. Under here we have the batteries that you can test by looking at the things. You can take them out and replace them like so. So when we turn the monitor on, it's going to go automatically into defibrillator mode. We can change that by pushing energy select and entering manual mode. And we tap the speed dial and we change the monitor to 50 joules for test purposes. Before every shift you want to run a user test. You can do this by pressing options, getting down to user test, and it's doing a user test now. Once the user test has finished, it will print out a strip of paper saying that the user test has passed. Sweet, so user test has passed. To do a test load, we put the test load onto the defibrillator cable like so, and then we press charge. It's charging to 50 joules at the moment. We don't want to touch it because it is live. To shock, we press the shock button. The shock has been charged. If we do this again, we can charge it up to 50 joules, and we can abort by pressing the speed dial there. And we can go into our lead, our free lead view. So to go into free lead view, you press lead, head on down to free, 2-1 free, and that's going to give you views of the heart. So Martin's just got it on at the moment, and we can see his heart rate is at 105. To hear the heartbeat, we can use our speed dial to select heart rate, and go into QRS volume, selecting that, and we can hear the heart rate like so. This is good for monitoring it. We turn it down just the opposite way, and we press home to go back. To raise the amplitude of the lead view, we just select it with the speed dial, and we go to size, and we can raise it up to say 3 times the size, and press home, and it's much bigger now. to change the paper in the monitor, you go down into the printer cartridge down here. You can just pull it out like so. Change it if you need to. Pull it out, making sure it doesn't jam. And then to print, just press the print button here, and it's going to print out the views of his heart, and it's much more accurate than looking at it on the screen. Apply the cuff like you would a normal blood pressure cuff, and press the NIB blood pressure, and it will give you a blood pressure on the side over here. Your ETCO2 gets put into here, this plug here, and you just use a bag valve mask to get your patient to breathe in there, and it will give you their CO2 readings. You get back to defibrillator mode, just press
Analyzing now.
Analyzing.
Stand clear.
But
no shock advised. Start CPR.
like so. When a lead falls off, it will show up as a dotted line. This does not mean asystole, it just means that a lead has fallen off and you need to reattach it, like so. So on approaching the scene, we're looking for any dangers, we're looking for any cars, any broken glass, anything that could be of harm to us. So the scene looks pretty clear, so we're going to get to work. Hello sir, ambulance here. He's not responding, so I'm going to use this pain stimulus. Hello sir, can you hear me? He's not responding. I'm going to look at his airway. So his airway looks pretty clear. I'm going to open it up, and I'm going to look, listen and feel for 10 seconds. So he's not breathing. Can I get you to start CPR, please? So while he's doing that, I'm going to start getting the AED ready.
Analyzing heart rhythm. Do not touch the patient.
Alright, I'm AUT1 to comms, R49 requesting at R50.
Pause. Start CPR.
Start CPR, please. So I'm going to get my oxygen ready to ventilate the patient. We're going to have a flow rate of 15. I've also got the suction here ready just in case we need it. I'm going to insert an OPA. Can you tell me when you get to 30?
Yeah. 27, 28, 29, 30.
Looking for good chest rise. There's good chest rise there. Right, so now I would ask the bystanders for a patient history, see what happened, if anybody knows what happened, if there's any family, friends, or anything like that around that could help.
27, 28, 29, 30.
So there's nobody here that can help me, so we're just going to work on them like this for the moment. Good CPR is 100 to 120 compressions a
27,
minute.
28, 29, 30.
At a rate of 30 compressions to 2 ventilations. You want to compress to 1/3 of the depth of the chest to get a good CPR.
27, 28, 29, 30.
At 2 minutes, we're going to swap over.
Seven, 28, 29, 30.
Stop CPR.
Stop CPR, please.
Analyzing heart rhythm. Stay clear of patient.
Stay clear.
Shock advised.
Alright, so the shock advisor is just going to charge.
Deliver shock.
Alright, I'll get everybody staying clear. Don't touch the patient, please. We're shocking now.
Shock delivered.
Shock delivered. I'm going to start CPR. Can you do ventilation
Start
first aid?
CPR.
Twenty-six, 27, 28, 29, 30. Good chest rise. Good chest rise.